Take a moment and just look at this waveform. You'll notice it doesn't disappear all at once. It fades. Each breath is a little smaller than the one before it and has a different morphology. The capnogram is shrinking, not because the patient suddenly stopped exchanging gas, but because the exhaled CO2 is escaping somewhere other than the detector. A gradual loss of waveform is almost always caused by a leak, and leaks are sneaky. A mask that was sealed a minute ago loosens as the patient moves. A supraglottic airway that looked perfect on insertion shifts just enough to let gas escape around the perimeter. An endotracheal tube cuff leak. Even subtle developing apnea can look like this, with the patient progressively breathing less until the machine is capturing almost nothing. Every time the waveform shrinks, remember the big three systems. Metabolically, nothing changed. The cells are still making CO2. Cardiovascularly, nothing changed. The heart is still delivering it. Respiratory mechanics are the culprit here. The CO2-rich gas that should reach your sampling line is venting into the room, into the esophagus, or around an airway device that's no longer tight. So in the first seconds, your job is simple. Check the circuit before you check the patient. Look for a loose mask strap, a kinked nasal cannula, a deflated cuff, or perhaps a displaced supraglottic airway. Then widen your lens. Is the patient tiring? Are tidal volumes diminishing? Are their chest movements slowing? A gradual fade is a warning. Something is slipping, either the equipment or the patient, and if you catch it now, you prevent the slide into complete respiratory failure. Now compare that to this waveform. There's no fade, no warning, no taper, it's just gone. A normal waveform and then flat. When capnography drops off a cliff like this, it means one thing. CO2 is no longer reaching the detector at all, and that is always an emergency. Start with the respiratory system. A sudden apnea, whether from sedation, seizure termination, neuromuscular failure, or an unexpected arrest, immediately stops gas from moving. A kinked endotracheal tube, a disconnected ventilator circuit, or a sampling line ripped off during patient movement can do the same. A fully dislodged tube, especially one now sitting in the esophagus, will give you a perfect flat line. If the airway is intact, shift to the heart. A sudden cardiac arrest produces the exact same pattern. When circulation stops, CO2 delivery to the lungs stops with it, and the waveform instantly disappears. It can't be a metabolic issue, the cells don't shut down this fast. A metabolic cause never eliminates a waveform in milliseconds. Only airway, ventilation, or perfusion collapse can create this kind of cliff. So what do you do in those first seconds? You go straight down the critical pathway. Is the patient breathing? Is the tube still in? Is the bag moving easily? Is the ventilator connected? Is the chest rising? And if all of that is intact, check a pulse immediately. A sudden loss of waveform is often the earliest sign of cardiac arrest, appearing before monitors or clinicians notice anything else. Thanks for watching. If you found this helpful, go ahead and like the video and subscribe to the channel so you don't miss the next one. And if you want the full masterclass, along with tons of other high-yield medical education, visit academy.emergeprep.org. And I'll see you in the next lesson.